Good evening, respected senior faculties of anesthesiology, colleagues, and my dear friends. First of all, I would like to thank our head of the department, Dr. Vandana Kulkarni Madam, for giving me an opportunity to present a topic in a national level CME conducted by the Department of Anesthesiology, WIMS, Wayanad. I would also like to thank Lavanya Madam for chairing the session and helping me in preparation of the topic. Thank you, Madam. So the topic assigned to me is mechanical ventilation strategies in pediatric age group. So before going to the topic, I'll be explaining the topic in the following headings. Why the mechanical ventilation in pediatrics is different from that of adult mechanical ventilation. Then we will talk something about the basics of mechanical ventilation and some basic modes of mechanical ventilation, and we will discuss few newer modes of ventilation and some recommendations regarding initiating mechanical ventilation pediatric age group. So we ventilate the pediatric patients to ensure adequate gas exchange, ameliorate the respiratory distress, enable resolution of pulmonary or other disorders, and protect the lungs from aspiration, and also to facilitate anesthesia and surgery. Even though we ventilate a lot of pediatric patients every day, it's always a challenge to the critical care physician as well as anesthesiologist to ventilate pediatric patients, because there is a paucity of randomized controlled trials and recommendation for pediatric mechanical ventilation. So now what we are doing is to extrapolate the studies from adults as well as individual experience to the pediatric population. But we know the children are not small adults. They are unique and they are special. They have a different physiology compared to that of adults. So what are the physiological changes of pediatric lung compared to that of adults? Regarding the compliance and resistance, as you can see in this picture, the pediatric, the ribs are horizontally arranged and the diaphragm is more horizontal. And the compliance of the lung is very low compared to that of adults. And it becomes more significant at low respiratory rate. When we look at the chest wall is highly compliant. And regarding the airway, as the airway in pediatrics is very narrow, there is a high airway resistance also. As you can see here, in adults, during inspiration, when the diaphragm moves downwards, the chest moves outwards, creating an effective negative intrathoracic pressure. Whereas in pediatrics, when the diaphragm moves downwards, because of the high compliance of the chest wall moves inward. So it is less effective in creating a negative intrathoracic pressure here. During expiration, the diaphragm comes back to the normal position. At that time, the chest wall moves outwards. So there is an imbalance between the lungs inward and the thoracic outward recoil in pediatrics. Regarding the functional residual capacity, as you can see here, it is very low in pediatric age group. It is as low as 15% of the vital capacity compared to that of 30% in adults. Regarding closing capacity is the volume of the lung at which the alveoli start collapsing. In adults, the closing capacity is far below the functional residual capacity. But as the functional residual capacity is very low in pediatric age group, even during normal expiration, there is a tendency of the alveoli to collapse. That means the closing capacity in pediatric age group is within the tidal volume. So there is a high chance of atelectasis in pediatric age group. Regarding ventilation perfusion ratio and dead space, as we know, the diameter of the airway is low in pediatric age group. The airway resistance, the dead space is very high in pediatric age group. The ventilation perfusion ratio in adults is there is an increase in ventilation perfusion from apex to the base. But in pediatric age group, the ventilation perfusion both are more at the apex than the base in 35% of the individual. And in 15% of the pediatric population, the ventilation and perfusion increases towards the base. And in remaining 50% of the pediatric patient, actually the ventilation perfusion ratio is variable in different parts of the lung. And regarding the effect of anesthesia on lung physiology, the functional residual capacity is reduced by 15% after induction of anesthesia, and it is further worsened by the administration of neuromuscular blocking agents. And as there is a reduction in the functional residual capacity, de-recruitment and airway closure occurs. And in 80% of the children shows basal atelectasis after induction of anesthesia, because we usually pre-oxygenate the patient with 100% oxygen, so there is high chance of absorption atelectasis after induction of anesthesia. And endotracheal tube increases the airway resistance in pediatric age group, but the studies shows that the airway resistance produced by the difference in endotracheal tubes are least at normal gas flows. So this is a table showing the effects of various anesthetic agent on the lung physiology. You can see here that the ketamine has got the least influence on the lung physiology, especially the functional residual capacity. So, because of the immaturity of the respiratory control and the reflexes, the small size of the airway and the collapsibility of the airway, lower efficiency of the respiratory musculature, imbalance of the chest wall and the lung compliance, a dampened ventilatory response to the hypercapnia, and increased oxygen demand in pediatric age group, they are more prone to develop respiratory failure. So mechanical ventilation is to support or replace the normal ventilatory pump moving the air in and out of the lungs. It can be broadly divided into positive pressure ventilation and negative pressure ventilation. Our normal respiration is negative pressure ventilation, and it can be either an invasive or a non-invasive mechanical ventilation. So what is the difference between a spontaneous ventilation and a controlled ventilation? In spontaneous ventilation, there is an increase in ventilation to well-perfused areas of the lung, whereas in controlled ventilation, it increases the ventilation to already ventilated, poor perfused areas of the lung, so that it increases the shunt fraction, whereas spontaneous respiration reduces the shunt fraction. There is an increase in cardiac output in spontaneous respiration because negative intrathoracic pressure will facilitate venous return. There is a reduction in cardiac output in controlled ventilation because positive pressure ventilation will reduce the venous output. So, spontaneous respiration, there is reduces the ventilation perfusion mismatch, whereas controlled ventilation, there is an increase in ventilation perfusion mismatch. So, it's always better to maintain spontaneous ventilation whenever possible during mechanical ventilation. So, going to the basics of mechanical ventilation, we should know three terms, that is trigger, limit, and cycle. Trigger is nothing but what causes the breath to begin, and limit or control means what regulates the gas flow during the breath or what should be achieved during an inspiration, and cycle means when we should shift from the inspiration to expiration. The triggering can be either the machine triggering or by the patient triggering. The patient triggering is again divided into pressure triggering and flow triggering. In pressure triggering, the machine will continuously monitor the pressure inside the inspiratory limb. When the patient takes a breath, there will be a fall in the pressure inside the inspiratory limb. That will be sensed by the machine and will sense that the patient is taking breaths. In flow triggering, there will be continuous flow of gases through the ventilator circuit, and the machine will continuously monitor the flow both in the inspiratory limb as well as the expiratory limb. When patient takes a breath, there will be a fall in the flow in the expiratory limb of the circuit. That will be sensed by the machine and will understand that the patient is taking spontaneous breaths. So based on this, the breaths can be divided into three: a controlled or mandatory breath, or a spontaneous breath, or an assisted breath. In a controlled or mandatory breath, the triggering is by the machine and the limit and cycle is by the machine. In a spontaneous breathing, the triggering, the limit, and the cycling is by the patient. But in assisted mode, the triggering is by the patient, but it is limited and cycled by the machine. Regarding the ventilator graphics, it is divided into scalars and loops. Scalars are actually continuous record of the pressure, flow or volume changes with that of time. From here you can see that in volume targeted ventilations, the pressure scalar is actually an exponential rise, whereas the flow scalar is square shaped. In pressure targeted ventilations, the pressure waveforms are square shaped and the flow wave scalars are decelerating pattern. So by just looking at the ventilator graphics, we can know what is the mode of the ventilation. Regarding loops, it can be either a flow volume loop or a pressure volume loop. Pressure volume loop actually indicates the compliance of the lung. From this one, we can actually compare with the initial flow pressure volume loop and whether the compliance of the lung is worsening or improving. From the flow volume loop, we can actually identify the site of obstruction of the endotracheal tube or what is the level of obstruction. So coming to the basic modes of ventilation, it can be a controlled or continuous mandatory ventilation, it can be either volume control or a pressure control, assist control ventilation, intermittent mandatory ventilation, and synchronized intermittent mandatory ventilation. Controlled mandatory ventilation is also called intermittent positive pressure ventilation or volume controlled ventilation. It's actually time triggered, volume limited, and volume or time cycled ventilatory mode. Actually, the pressure is variable according to the changes in the compliance of the lung, and it allows complete rest of the respiratory muscles and thus reducing the work of breathing. And it ensures a constant tidal volume delivery. But the pressure generated will depend upon the compliance of the lung. If the compliance of the lung is very low, it will generate high pressure. Then controlled mandatory ventilation, pressure control. It's actually time triggered, but it is limited by the pressure. And cycling is by either flow cycling or time cycling. And the flow pattern is decelerating, so that the same tidal volume can be delivered but with a lower peak pressure. That is the advantage of pressure controlled ventilation over the volume controlled ventilation. And alveoli having a long time constant are more likely to be inflated in pressure controlled ventilation. And it is useful if the airway seal cannot be fully achieved, as in children with uncuffed tubes and also in patients with the bronchopleural fistula. And the unlimited flow during the inspiration, as you can see here, so there is no flow hunger for the patient. So this is the difference between the volume control ventilation and pressure control ventilation. Here the volume is limited, this volume limited, PCV is pressure limited. There is high chance of barotrauma in volume control ventilation if the compliance of the lung is very low. Again, in pressure control ventilation, if the compliance is very low, there is a chance that there can be low delivery of the tidal volume. And in both volume control ventilation and pressure control ventilation, it is unresponsive to minute ventilation requirement of the patient, and patient breaths are not at all allowed. And there is high chance of patient ventilator dysynchrony, and we need to sedate and paralyze the patient to give controlled mandatory ventilation. Assist controlled ventilation is actually can be either time triggered or patient triggered, but all the breaths are of identical duration, and it is volume or pressure limited and time cycled by the machine. So all the breaths are of identical duration, and the patient can increase the ventilation according to the ventilator need of the patient. And it do not allow the patient to take spontaneous tidal volume, but a preset tidal volume only. But patient can control the respiratory rate. It also provides full respiratory support for the patient. But the problem is that when the patient is hyperventilating, all the breaths will be controlled by the machine. So there is a chance of respiratory alkalosis, and the drive may be lost. Intermittent mandatory ventilation, it allows the patient to breathe between controlled breaths. And the controlled breath can be either a volume control or a pressure control. The patient can adjust the rate according to the ventilatory needs. And the mandatory breaths are actually time triggered, volume or pressure limited, and time cycle. The rate and tidal volume of spontaneous breaths are patient controlled only. So even though the patient breaths are allowed, there are mandatory breaths. So, and there is no synchrony between the patient breath and the mandatory breath. So the chance of breath stacking, dyssynchrony, and barrel trauma are still there. So in order to rectify that, synchronized intermittent mandatory ventilation came. Here the patient can increase the ventilation according to demand. There is preservation of the spontaneous breath. The tidal volume is assured in synchronized intermittent mandatory ventilation in volume control mode. And there is no risk of barotrauma if it is in a pressure targeted ventilation. And there is a reduced requirement of sedation, reduced patient ventilator dysynchrony, and patient has increased work for spontaneous breaths. So here you can see that the patient is allowed to breathe in between the controlled breaths. And in controlled breaths itself, there is a time period which is called the synchronization window, in which the machine will check whether the patient is taking breath or not. If the patient is not taking any breath, the machine will deliver a controlled breath. And if the patient is taking a breath, that will be assisted by the ventilator. But the problem is that the breath taken by the patient in between the mandatory breaths are not assisted. So there is chance of increased work of breathing for the patient for spontaneous breaths. So to avoid the increased work of breathing during the spontaneous breaths, if we can support the spontaneous breaths with a pressure support, that will reduce the work of breathing. So synchronized intermittent mandatory ventilation with a pressure support ventilation will be more better than a synchronized intermittent mandatory ventilation alone. So the work of breathing of the patient can be reduced if we add pressure support to the spontaneous breaths which are taken by the patient in between the mandatory breaths. Regarding PEEP and CPAP, actually both are the application of positive pressure throughout the respiratory cycle. If it is in a control or assisted mode of ventilation, this is called PEEP, and if it is in a spontaneously breathing patient, it is called CPAP. It helps in preventing the de-recruitment and to promote recruitment. It protects the lung from ventilator-associated lung injury. It assists in cardiac performance during cardiac failure. Increases the functional residual capacity and decreases the work of breathing. As you can see here, when functional residual capacity is coming down, there is a chance of the collapse of the alveoli as FRC reaches the closing capacity. But if we apply PEEP, the FRC will be increased and will be far away from the closing capacity, so that the chance of atelectasis or the collapse of the alveoli will not be there. CPAP is actually continuous application of the positive pressure in a spontaneously breathing patient. The patient will be breathing at that higher pressure. So it will prevent the collapse of the alveoli also and will reduce the work of breathing. So again, in all these modes, there is either barotrauma or inadequate tidal volume delivery. So later, many new modes of ventilation came to meet both the requirements. There are different newer modes of ventilation. Some of them are volume assured pressure support, volume support ventilation, pressure regulated volume control, auto mode, adaptive support ventilation, proportional assist ventilation, inverse ratio ventilation, airway pressure release ventilation, neurally adjusted ventilatory assist, automated tube compensation, high frequency oscillatory ventilation, and smart care. Some of the newer modes of ventilation we will discuss here. First one is the volume assured pressure support ventilation. It's actually dual mode of ventilation. Here, it's actually a pressure targeted ventilation in which a particular amount of tidal volume will be delivered. We can set the required tidal volume for that particular patient. And if that tidal volume is not delivered in a single breath, it will automatically will be converted into a volume controlled mode and will deliver the preset tidal volume. So it's a pressure targeted ventilation. In that pressure targeted ventilation, if the tidal volume is not achieved, it will be automatically shifting to a volume control mode and that tidal volume will be achieved. In volume support ventilation, it is similar to that of pressure support ventilation. In a spontaneously breathing patient, if the tidal volume is not met, it will increase the pressure support given and will try to deliver the set tidal volume. Pressure regulated volume control. It's again a pressure targeted ventilator remote. It adjusts the tidal volume between breaths. Initially, it measures the tidal volume and compares with the set tidal volume. And if the tidal volume delivered is low, it gradually increases the pressure to deliver the same tidal volume, but it never crosses the set maximum pressure. And if the tidal volume delivered is more than the set tidal volume, it reduces the pressure support so that the set tidal volume will be reduced. So, according to the tidal volume delivered, it increases and decreases the pressure support. So, it's actually an ideal mode for weaning from mechanical ventilation. As you can see, as the tidal volume delivered is low, it increases the pressure slowly and finally it reaches the tidal volume. And if the tidal volume is adequate, it tries to reduce the peak pressure also, pressure support also. So here you can see that as the tidal volume delivered is adequate, it again reduces the pressure support. So actually the target of this mode of ventilation is to achieve the lowest pressure to deliver the set tidal volume. Another mode is airway pressure release ventilation. Here there are two levels of pressure which are delivered by the machine. It's similar to that of the CPAP. It gives a higher CPAP and a lower CPAP. The advantage is that the patient can breathe, take spontaneous breath both during the higher pressure and the lower pressure. And during the shift from the higher pressure to lower pressure, it will act as an exhalation and releasing the carbon dioxide. And even if the patient is not taking any breaths, the higher and lower pressure and the release in between will produce breaths, and uh, even if the patient is apneic, it will ventilate the lung. So you can see here that during the release, it will wash out the carbon dioxide. Another mode is high frequency oscillatory ventilation. It's actually giving very small tidal volume at a very high rate, and the oxygenation occurs through convection, diffusion, pen left movement, cardiogenic mixing, and collateral ventilation. It's actually used in severe cases for ARDS before going for ECMO. Another mode is neurally adjusted ventilatory assist. Actually, the ventilation is fully controlled by the CNS, and if there is increased requirement of ventilation, it will be triggered by the central nervous system, and it will increase the contraction of the diaphragm. And the excitation of the diaphragm can be directly recorded by an electrode placed at the level of diaphragm. It will record the electrical activity of the diaphragm and it will deliver the breath as per the diaphragmatic contraction. That is neurally adjusted ventilatory assist. So mechanical ventilation has undergone continuous evolution with newer modes of mechanical ventilation to reduce the barotrauma, volutrauma, and dysynchrony. But no data exists so far to determine the ventilatory mode that provides the greatest benefit with the minimum risk of ventilator-induced lung injury. So, the European Society of Pediatric and Neonatal Intensive Care initiated a consensus conference, that is Pediatric Mechanical Ventilator Consensus Conference, to form some recommendations for initiating mechanical ventilation in pediatrics. So, as per the guidelines, for pediatric age group, both high flow nasal cannula and CPAP are effective to reduce the work of breathing. There are no outcome data showing superiority of either of these one over the other. And the non-invasive ventilation can be considered before resorting to intubation, but intubation should not be delayed based on the NIV. If the patient is not improving on NIV after say after 1 or 2 hours, we have to intubate and initiate mechanical ventilation. And regarding the use of cuffed and uncuffed endotracheal tubes, the earlier belief was that the airway of the pediatric patients are funnel shaped and the subglottic area is the narrowest part. But now it is proven that both the glottis as well as the subglottic area are narrow in pediatric age group. And also, the anteroposterior diameter of the trachea is more than that of the transverse diameter in pediatrics. So when we introduce an uncuffed tube, there is high chance of leak through either anterior portion or the posterior portion. So now it is recommended that we can use cuffed endotracheal tube for pediatric age group also. Regarding the mode of ventilation, in pediatric age group, the pressure targeted ventilation are usually preferred over the volume targeted ventilation, but it should be based on the disease condition of the patient also. And there are insufficient data to recommend the use of high frequency oscillatory ventilation in pediatrics, except for severe cases of ARDS before going into ECMO. And in intensive care, if the patient is receiving neuromuscular blocking agent, it is better to have a pressure regulated volume control mode of ventilation. And if the patient is having spontaneous breath, it is better to have a synchronized intermittent mandatory ventilation, either pressure or volume targeted. Ventilator settings, the trigger should be adjusted to ensure the patient ventilator synchrony, and all children on respiratory support should breathe spontaneously. So we should avoid muscle relaxant maximum. So the tidal volume should be ideally 6 to 8 ml per kg. There are data showing that tidal volume of more than 10 ml per kg is associated with bad outcomes. And the plateau pressure should be limited to less than 28 centimeter of water in a normal lung, or 28 to 32 if the lung compliance is low. And we have to keep the delta pressure less than 10 centimeter of water, and we can keep an initial peep of 5 to 8 centimeter of water. And regarding IE ratio, it should be adjusted in such a way that we have to see whether the expiration is complete or not. The oxygenation is targeted to get an oxygen saturation of 90 to 97 patients in ARDS with a PEEP of less than 10 centimeter, and 88 to 92% when the PEEP is more than 10 centimeter of water. And ventilation should be adjusted to have a PCA2 between 35 to 45 millimeter of mercury, and the pH should be more than 7.2. And they recommend the use of humidification for pediatric age group also. And regarding endotracheal suction, do not perform endotracheal suction routinely unless it is indicated. And the installation of isotonic saline prior to suctioning is also not recommended. And maintain a head up position of around 30 to 45 degree for better lung function. And endotracheal tube, use of cuffed endotracheal tube is promoted, and keep the cuff pressure to less than 20 centimeter of water. And always try to use double limb circuit for invasive ventilation in pediatrics. So the take home message is that the children are not small adults. The lung physiology is entirely different from that of the adults. So we should have an elaborate knowledge about the lung physiology before initiating mechanical ventilation in pediatrics. And there are a lot of modes of newer modes of ventilation which are effective in preventing barotrauma, ovular trauma, and dysynchrony that we can use for ventilation. And actually there lacks a randomized control study to form recommendation for pediatric mechanical ventilation. The art and science of pediatric mechanical ventilation is by no means settled, and incremental improvements in our understanding continue to be made. Thank you.